Welcome to this deep dive into the complexities surrounding homelessness.
It's a huge topic.
It really is.
Yeah.
Today, we're looking at it from a few angles. We've got insights from an investigative journalist, a professor, and importantly, someone with direct lived experience.
Right. Someone who's been through the mental health system and experienced homelessness firsthand.
Exactly. And we got some really thoughtful questions from listeners. So our aim today is, well, to unpack some common assumptions and maybe shed light on the less visible realities here.
Yeah, and the sources you've pulled together are quite powerful. We're drawing from a YouTube discussion with Rob Wand. He wrote, "Your consent is not required." Philip Llanos, a professor researcher at CUNY,
Hmm.
and Patrick, who's a documentary filmmaker with that lived experience we mentioned.
Their conversation really challenges the dominant narratives, doesn't it?
It absolutely does. It highlights things that often get, glossed over or missed entirely.
Okay, so let's start digging in. First up, Rob Wand, the investigative journalist. He looks really closely at media portrayals. He argues there's this kind of dominant stereotype.
Yeah, he does.
What are the key elements he found in that stereotype?
Well, according to Wand, it's surprisingly consistent. It's almost always male, labeled homeless, and often described as severely psychotic or having schizophrenia.
Okay.
And there's usually this undercurrent, this implication of potential violence or criminality.
Right, that danger element.
Exactly. The term anosognosia comes up a lot. That's the idea someone isn't aware of their own illness, and they're often just dismissed as out of touch with reality.
And are these individuals actually interviewed?
That's a key point one makes rarely. We usually hear about them, often from, say, concerned family members.
So it paints a specific picture.
It really does. One argues it boils down to portraying the homeless individual, especially one with mental health struggles, as this sort of dangerous other. It kind of strips away their humanity and ignores the diversity of experiences.
But why is that specific portrayal such a problem for Juan? I mean, some situations are very difficult.
Sure, but he argues it's fundamentally dehumanizing. By focusing only on these, extreme or stereotypical cases and just taking family narratives at face value.
Without questioning them.
Right. The media fails to show the huge range of experiences. And phrases like out of touch with reality, well, Juan says they're just dismissive. They don't help us understand the person's actual struggles or even their strengths. It just creates this broad, negative brushstroke.
And he mentioned how just a few words can conjure up this whole negative image, right? Like instant prejudice.
Yeah, exactly. These trigger phrases.
What were some examples he gave?
Oh, things like shouting on a street corner, harassing people, maybe walking barefoot downtown, hearing voices, or shadow boxing.
Okay, yeah. I can picture those images.
And the really alarming one, pushed someone onto subway tracks. These aren't descriptions of patterns. They're just quick, vivid snapshots meant to provoke fear, really.
Now, one also talked about pushback. When people critique this narrative, how do others typically respond? What tactics does he see?
Right, because these narratives are pretty entrenched. He notes critics often get hit with demands for, immediate, simple fixes.
As if complexity means inaction.
Precisely. Or there's a hyper-focus on very rare, high-risk events, totally ignoring the person's whole life context. He also points to this, false choice. Force versus doing nothing.
Oversimplifying it.
Totally. And there's often this underlying assumption that the individual has zero reasonable capacity, zero agency, plus this almost blind faith in psychiatric medication as the only answer.
So he calls that dominant narrative itself out of touch with reality. What does he think is a more accurate picture?
This is where it gets really interesting. One emphasizes the episodic nature of these struggles. People aren't just one thing all the time.
Right, they have ups and downs.
Exactly. Periods of more stability, connection. He pushes for things like robust peer support, crisis care that feels welcoming, not punitive.
Non-coercive options.
Yeah. Yes. Non-coercive therapy, practical support, like real-world help in the housing first model, but with strong supports built in. Even financial help for caregivers chosen by the person themselves. It's much more nuanced.
And crucially, he questions this idea that severe mental illness is, well, the main driver of homelessness for most people. He challenges that link between deinstitutionalization and mass homelessness.
Yeah, that's a big one. It's a very common assumption.
So what evidence does he bring?
He cites quite a bit of research, actually. 23 studies across 12 different Western countries that followed people after they left institutions.
And what did they find?
Overwhelmingly, a minimal connection between discharge and ending up homeless or in jail, really minimal. Many studies found 0 cases, others maybe less than 2%.
Wow. So that narrative seems shaky.
It really undermines the idea that just opening the hospital doors directly caused mass homelessness. The evidence suggests that's largely a myth.
So if they weren't ending up on the streets, where did most of those people go?
The data points towards transitions into group homes, supportive housing, long-term care facilities, basically other forms of supervised or supported living.
Okay, that paints a very different picture. Now, what about those stats we often hear about mental illness rates among the homeless? That California survey last year, for instance.
Right. The California survey, it's found, I think, 82% reported experiencing a serious mental health condition at some point in their lives, 69% anxiety, 23% hallucinations. The numbers sound high.
They do sound high, but one urges caution here. Why?
Yes, major caution. He points out several things. First, these surveys don't control for the impact of homelessness itself on mental health. Being homeless is incredibly stressful.
Of course, it could cause or worsen symptoms.
Exactly. Second, they often lump substance use disorders in as mental illness. Third, there's what he calls diagnostic inflation in surveys generally. Fourth, they use lifetime prevalence rates ever had it not current rates.
Ah, lifetime versus current. That's a big difference.
Huge. And finally, the most crucial point. They often lack comparison to the general population.
Okay, so when we do make that comparison using lifetime prevalence, what does the data show?
Well, it's surprising. Lifetime rates for mental disorders in the general population are actually estimated to be somewhere between like 61% and 80%.
So, similar or even lower than the homeless stats sometimes cited.
Potentially, yeah.
Yeah.
Similar, maybe even a bit lower in some comparisons. And for hallucinations, the lifetime prevalence in the general population also has a huge range. Some studies show 15%, others up to 80%. It's not as uncommon as people might think.
So if one argues severe mental illness isn't the primary driver as often portrayed, what does he think is the real driver?
His core argument points to the policing of unhoused populations, criminalizing homelessness itself.
Criminalizing survival. What evidence does he have for that? That's a strong claim.
It is. He points to the huge increase in city bylaws across the U.S. targeting basic survival acts, sitting, lying down, camping, even loitering.
We see that happening.
Yeah. LA, San Francisco, dozens of these ordinances. He also highlights data from San Francisco showing calls to 911 or 311 about homelessness skyrocketing way faster than the actual homeless population grew.
So more complaints per person.
Massively more. And in Portland, Oregon, arrests and psych detentions of homeless individuals actually exceeded the official federal count of homeless people there.
Exceeded the count. Wow.
Yeah. Plus, the Department of Justice has even sued cities because people were effectively being locked up due to a lack of supportive housing.
And what was the result of all this increased policing? Did it solve homelessness?
According to Juan, not at all. It mainly led to what he calls burden shuffling.
Just moving people around.
Pretty much, move them here, they pop up there. It makes poverty more visible, which ironically fuels more complaints, but it doesn't address the root causes like lack of housing.
Why does one think this perspective, focusing on policing and systemic issues, isn't the dominant one in public discussion?
Well, his theory is that it shifts the blame, doesn't it? Away from the easy stereotype of the severely mentally ill individual
And
towards much harder systemic issues, things like mass incarceration, the housing crisis itself, ineffective bylaws, the lack of rights and support for unhoused people. It would also mean scrutinizing the motives of complainants, maybe even questioning the mental health system's role. It's uncomfortable.
Much more complex.
Much more.
Okay, let's shift now to Patrick's story. Hearing from lived experience is so crucial. What was going on for him leading up to his first mental health crisis in 2018?
Patrick shares it was near the end of a really tough 2-year divorce process. He was dealing with deep depression, feeling isolated, lonely, even having suicidal thoughts. And he mentioned experimenting with microdosing LSD, which unfortunately seemed to trigger psychosis for him.
And his experience at Mercy Hospital, can you describe that? It sounds like it was deeply traumatic.
Yeah, he describes being tied down, physically restrained in a 4-point hold, arms and legs strapped to the bed.
Oh my goodness.
He was forcibly medicated, given drugs without anyone explaining why or even asking about his situation, then just discharged. No transport, no food, no follow-up, nothing.
That's appalling.
And understandably, it led to severe PTSD for him and was a major factor in him becoming homeless.
How did he initially process that? What did he think about what happened?
It's heartbreaking, really. He internalized it. He believed it was somehow his fault.
He blamed himself.
Yeah. It wasn't until years later, a chance encounter with the director of NAMI in Kansas City, that he started to see it differently, to understand that what he experienced was abuse.
Did anything positive eventually come from his speaking out about Mercy Hospital?
Thankfully, yes. Because he shared his story, Mercy ended up implementing mandatory nonviolence and de-escalation training for staff and patients in the ER and psych unit.
That's significant.
Huge. They also stopped using those four-point restraints and started involving patients more in their own medication and recovery decisions, moving away from just forcing meds.
And he volunteers there now.
He does. He has an open invitation to play music for patients on the psych unit. And he says the patients he talks to now report being treated with respect. They might complain about the food or the decor, but the care itself, they say, is much better. Some even say it's the best place they've been treated.
That's a powerful turnaround.
Right.
But he also had another difficult experience later at St. Vincent de Paul.
Unfortunately, yes. He actually filmed part of the interaction as they were taking him to the hospital. He told the doctor specifically about his trauma with forced Haldol at Mercy.
The same drug.
The exact same drug. And despite that, nurses tried to give it to him again. Then an orderly became violent, grabbed him by the throat, slammed him against a wall. He briefly lost consciousness.
Unbelievable.
He was put in restraints overnight, and when he told the doctor about the assault, her response was just, "You shouldn't have resisted."
Really blaming him again. How did these experiences impact him long term?
More trauma, obviously. It contributed to another period of homelessness. He's very clear. These coercive, sometimes violent interventions solved nothing. They didn't help him with the underlying issues at all.
So what did help him? What factors does he credit with getting him through?
It really comes down to human connection and basic needs. Having shelter was critical. The support of specific friends in Kansas City. He mentions David and Garrett, his sister offering him a place in Springfield. And just friends checking in, those small acts during his lowest points. Those were lifelines.
What are the main takeaways for him? His key conclusions from all this?
He boils it down to three main things. First, loneliness. He sees it as both a cause and something that keeps mental illness going.
Isolation is so damaging.
Absolutely. Second, the need for a supportive community to heal instead of isolation and coercion. And third, the huge impact of small acts of kindness. They really matter.
And what does he want to do now?
His real desire now is to connect with others who are in those low places, as he calls them. He wants to reach people who might feel unseen, recognizing their sensitivity and intelligence that often gets overlooked. Just offer that connection.
He also mentioned discovering alternative care models. Soteria houses, what are those?
Yes, Soteria houses, they're basically regular homes, right, in a neighborhood, not institutions. They're staffed often by people who've had their own experiences with psychiatric distress or abuse.
Peer support built in.
Exactly. They offer a safe place for people in crisis, even psychosis, good food, therapy options, and crucially, medication isn't forced. It's a choice.
And how do they compare, cost-wise and benefit-wise, to a typical psych unit?
Patrick makes a stark comparison. He says the cost for a week in a Soteria house can be less than 1 day in a standard psych unit.
Wow.
And the benefit to well-being, he argues, is just tremendous in that less coercive, more supportive environment.
Okay, that brings us to our final perspective, Professor Philip Janos. He looks at this from a clinical and research angle, particularly working within coercive systems.
Right. His focus is specifically on assisted outpatient treatment, or AOT orders in New York City.
Why is that therapeutic relationship, the connection between clinician and client, so vital, especially with people diagnosed with psychosis?
Janos really emphasizes this. He says it's the foundation, trust, especially for people who've been marginalized or traumatized, which is often the case. Without that trust,
They might not engage.
or follow through.
Exactly. They might not adhere to treatment. They might just disengage entirely. A good relationship involves, a bond, agreement on goals, agreeing on the tasks, mutual respect, trust, fairness, collaboration, all those things.
Does research show this relationship actually impacts outcomes? Does it make a difference? It does. Several meta-analyses show a positive effect. It's maybe small statistically, but it's significant and consistent. It impacts symptoms, medication use, self-esteem, even reduces hospitalization rates separate from the specific therapy technique used.
So how does coercion creep into that relationship? It's not always obvious, is it?
No, it's not always forced hospitalization or an AOT order. That's overt coercion. But it can be subtle, too, suggestions, hints of negative consequences if someone doesn't comply with what the clinician recommends.
And what does that coercion do to the relationship? Does it always damage it?
Intuitively, you'd think, yes, it undermines trust, and some research backs that up. But interestingly, some studies find coercion can actually increase treatment adherence, like showing up for appointments because you have to.
But showing up isn't the same as having a real alliance, right?
Exactly Janos's point. Compliance doesn't equal genuine connection or trust.
Janos mentioned working with the late at night. They talked about dueling imperatives in the mental health system. What do they mean by that?
They saw this fundamental tension, healing versus social control. Is the system primarily trying to help the individual heal, or is it primarily trying to manage behavior and control perceived risk?
That's a critical distinction.
And a key point they made was the need for honesty. Call interventions what they are. Don't disguise social control measures as being solely about individual therapy or healing.
Okay, so explain AOT in New York State. How does that work?
AOT is a court order. It mandates someone follow a specific treatment plan for up to a year. If they don't comply,
What happens?
they can face involuntary removal, basically, being picked up and taken for a 72-hour psych evaluation, which could lead to involuntary hospitalization. Clients often describe these removals as, well, humiliating, dehumanizing.
What led to AOT being created in New York? It was called Kendra's Law originally.
Yes, Kendra's Law. It came about after the tragic death of Kendra Webdale, who was pushed onto subway tracks by a man with a history of mental illness.
So the justification was preventing dangerousness.
That was the public justification, yes. Preventing danger, breaking that cycle of decompensation, dangerousness, hospitalization. That's what a judge cited.
But what are the actual legal criteria for getting an AOT order in New York? Is it just about immediate danger?
That's the surprising part. No, it's broader. You can get an AOT if you have a history of non-compliance with treatment twice in the last 36 months. Or if your condition was a major factor needing hospitalization twice in that same period, plus other criteria about needing treatment to prevent relapse. So it's not just about immediate violence risk.
And based on New York's own data, what percentage of people on AOT in NYC actually had a history of physical assault before the order?
Only 12%.
12. So 88% did not have a documented history of assault.
Correct. Which really challenges that original preventing dangerousness justification.
What about other research? Lauren Gonzalez used an objective risk measure, the HCR2.
Yeah, the HCR2 is like a standardized tool using data to predict risk. Gonzalez found 67% of AOT clients had no recorded violence history, and the HCR2 rated 46% as low risk.
But clinicians rated them higher.
Clinicians were more likely to label the charts as high risk, but the actuarial measure only put 19% in the high risk category. So the takeaway is AOT isn't mainly targeting high violence risk individuals, despite the law's origin story.
How common is AOT for people working with ACT teams' assertive community treatment in NYC?
It's pretty common. About 21% of ACT clients in the city are also under AOT orders.
That seems like a clash, doesn't it? ACT is supposed to be voluntary, relationship-based?
Exactly. There's a real disjoint there, trying to build trust voluntarily while simultaneously having this coercive court order hanging over things.
What are some experiences clients on AOT shared with Janos?
He shared a couple, an older adult who felt branded a criminal by the AOT order, despite no violence history, just because she had this label. Another client with anxiety became terrified of forced removal for tiny mistakes, which made her less honest and more socially avoidant.
So what did Janos' own research comparing ACT clients with and without AOT find?
Quantitatively, looking at surveys, he found no significant difference in the reported therapeutic alliance strength.
So the ACT teams were managing to build relationships despite the AOT.
It suggests they often work really hard to overcome that barrier, yes, but qualitatively, when they actually talk to people, it was different.
How so?
About half the AOT participants brought up themes of paternalism, feeling coerced in their referral or treatment decisions, but none of the non-AOT participants did.
Can you share some quotes that illustrate that?
Sure. One person said, "I didn't have no say in anything," feeling AOT was the only way out of the hospital. Another acknowledged ACT support, but felt medication decisions were not fair and didn't respect their opinion. A third described it as dialogue, but ultimately, I have to do what he says.
What are the implications here? What should we take away from this?
It really highlights the need to think carefully about how coercion impacts genuine engagement. Janos suggests clinicians should ideally be able to talk openly with clients about the coercion, about the AOT, and try to help them move towards more voluntary participation over time.
And Janos connects us back to homelessness, too. What's happening in NYC now regarding unhoused individuals?
He points to the current mayoral administration pushing for more coercion, these scout teams actively accosting people in public.
Accosting them.
Yeah, he shared one person's reaction when approached. Just, please leave me alone. What did I do wrong? It really captures that feeling of being targeted.
We talked about the traditional continuum of care for homelessness. Janos mentioned housing first as an alternative. Could you remind us how that works?
Right. Housing First flips the script. Instead of making people go through steps to earn housing, it provides immediate access to independent housing first, and then pairs it with high-intensity treatment and support.
And started in New York City.
Ironically, yes, back in the 90s.
How does it stack up against the continuum of care in terms of effectiveness?
Meta-analyses consistently show Housing First is substantially more effective at getting people housed and keeping them housed.
What about that big Canadian study at Soy?
That was a landmark study. It found dramatically better housing retention in the Housing First group. They also had better community functioning and quality of life compared to treatment as usual.
So the evidence seems pretty clear. Housing First works. It's less coercive. Why isn't it the main approach everywhere?
That's the big question. Janos's hypothesis. It doesn't sell politically right now.
Why not?
He points to the influence of media like the New York Times and certain policy groups, Treatment Advocacy Center, mentalillnesspolicy.org, that constantly push the narrative that the system is too voluntary.
Involuntary. What examples does he give of that sentiment?
Things like NYT editorial arguing for bringing back asylums. An opinion piece actually defending stigma. Quotes from policy analysts, even a former presidential candidate, suggesting people with mental illness are fundamentally different, dangerous, need to be removed from public view, a letter writer calling to just lock people up. It's a powerful narrative.
And Janos had a personal experience with this narrative being prioritized.
Yeah, when there were attacks on Asian people in NYC, he was interviewed by the Times and strongly rejected the idea that this was primarily a symptom of mental illness.
Yeah.
His categorical rejection was just omitted from the article, and an op-ed he co-wrote challenging that framing. The Times wouldn't publish it. It shows how hard it is to counter that dominant narrative.
Wow. This deep dive has certainly covered a lot of challenging ground. It's so clear how these dominant narratives about homelessness and mental health can really obscure the complex realities.
Absolutely. And how prejudice deeply shapes public perception and systemic responses. The insights from Rob, Patrick, Philip, they really expose the limits and the actual harm of approaches built on stereotypes and coercion.
Patrick's story especially just powerfully underlines that need for compassionate, person-centered care and the difference basic connection and stable housing make.
It really does. And Professor Janos's research highlights that tricky balance trying to provide support within systems that can feel coercive. How do we empower people while also addressing societal concerns? It's not easy.
So ultimately, it feels like the path forward involves really questioning our own assumptions, doesn't it? Challenging those stereotypes.
In prioritizing solutions based on empathy, respect, recognizing everyone's dignity, the call for things like housing first, for community-based alternatives like Soteria houses, it feels clearer and more urgent after hearing all this.
We really hope everyone listening takes some time to reflect on these perspectives. Think about how they might shape your understanding of what's happening in your own community.
Yeah, what stood out most? What questions does it raise for you? Because this really is just the start of a conversation we need to keep having.
Thank you so much for joining us for this deep dive.
We hope it's given you some valuable insights and maybe, just maybe, challenge some perspectives along the way.